congratulations. This is time for discussion now. Dr. Ekkapot Jitpun from Thailand and Dr. Chandan Mohanty.
Yeah. Hello.
Yeah, we'll start discussion, share some thoughts about these lectures and beyond about peripheral neurosurgery, and then we will continue with the legendary interview or interview with the legend.
Yeah. First of all, I would like to thank you all speakers for this wonderful and insightful session. I believe with such a short time frame, there would be a lot more details on each topic. On the first topic, the brachial plexus injury, I think it's still a problem here in many developing countries. I think what we all here experience is the delay referral, making the choice of surgery and the chance of recovery limited. So one thing is that is really important is timing, as Deborah has mentioned. So Deborah, what is the perfect time for referral? So we're here for young neurosurgeon. I hope that this must be emphasized for let them know about this issues.
Thanks, Jake, for your question. And first of all, I would emphasize that this is the reason why I actually chose to give a talk about the clinical management and the indications to assess a patient with brachial plexus injury, because unfortunately, this is still something that most neurosurgeons cannot do. So before we get into the topic of how to do the surgery, we have to know when to treat the patients. As I try to emphasize, the main core of the assessment, both clinically and radiologically, is the detection of the root avulsions. So if you have a root avulsion, you should not wait, because this is a reversible injury that cannot present spontaneous recovery. So this patient can only get restoration of function only with surgery. So if there are avulsions, considering the general overall situation of the patient, you should try to go for surgery as soon as possible. Now, I mentioned that you do the EMG and nerve conduction study approximately after 3-4 weeks from the causative mechanism, the causative injury. For MRI, we also wait approximately 3-4 weeks because otherwise it might not be clear the detection of the meningocele, because the pseudomeningocele also may take some time. And then we also have to consider what is the general condition of the patient. If there are no other medical conditions that prevent the patient to be operated, then I think the ideal would be to operate the patient as soon as you have the confirmation of the root avulsions on the radiological investigations. So as I said, if we could expect to have our patients operated between 1 and 2 months from the causative mechanism, that would be the ideal situation. If there are no avulsions, as I said, when you just have a post-ganglionic injury, then we can still, and there is hope that there might be some spontaneous recovery. But at the same time, we are not supposed to wait too long, because then if the spontaneous recovery does not occur, or the spontaneous recovery occurs insufficiently, then we have to go for surgery. So there is an agreement about waiting up to 3-4 months. And then after that date, if we do not see that there is an evidence of spontaneous recovery that can be detected on neurophysiology, so we have to follow up the patients with EMG and nerve conduction study, or also with clinical examination, then the patient should go for surgery. And I did not have enough time to mention that in my talk, but we all know that the best results are when the patients are submitted to surgery within 6 months from the injury. We can still get good results between 6 months and 1 year from the traumatic event, but the best results are those within 6 months. Timing is essential. The neurologists always say that time is brain, but as Christian Heinen usually says, time is also muscle. So the sooner, the better. Was I
So,
clear?
yeah, it's very clear,
Yes,
Deborah. Thank you very much. So,
thank you.
Carlos, is this the same concept applied to the facial nerve? I mean, for the timing.
Exactly. Yes, yes, yes. Also, when we consider facial nerve, I mean, this is not the most common topic for us as nerve surgeons, maybe in hospitals of reference. But I think that neurosurgeons and nerve surgeons should be familiarized with this pathology, with this entity, as I showed before. There are many techniques and strategies to improve nerve function. Usually, we need to combine this group of techniques. I mean, dynamic procedures with static procedures. And as Deborah said before, time is muscle. So the sooner the surgery, the best outcomes.
Carlos, so I had one question. I didn't see in your slides. Do you have any role of electrophysiology for facial nerve paralysis? Like when do you do it, if you do it?
I use neurophysiological investigations preoperatively, and for the use of intraoperative neurophysiological investigations, only when we need to consider decompression. I mean, none in when we suspect transections. Okay, so in these cases, it is not necessary. But we use neurophysiological intraoperatively for decompression after, by example, a trauma within the intratemporal or intracranial location. And obviously, the use of neurophysiological investigations is paramount to decide the best time for surgery.
Thank you. So I had one rather a comment on Christian's talk. It's an excellent presentation, Christian. In fact, I remember once, in fact, more than once, whenever we do patients with meralgia paresthetica, we don't find the nerve. Sometimes it has an anomalous course, and ultrasound really helps in finding the nerve sometimes to help you, especially when you're dealing with very obese patients or patients who have been operated in that area. So I think that is one. But thank you very much. So for emphasizing the use of ultrasound in a very systematic manner for peripheral nerve surgery. I think it was an excellent presentation.
Thank you, Jitpun.
Jake,
I
agree on that.
I totally. Oh, sorry.
Please,
You first, Kristen. First, please.
No, please go.
I totally agree with Chandan about the ultrasound. It's very helpful. But I see you do the ultrasound and you see the fascicle. I mean, you see the fascicle inside the nerve. Does the ultrasound have to be the high definition to illustrate small nerve and the nerve fascicle? I mean, yes, I do ultrasound sometimes, but I did not see the details that you see. That's very high definitive.
Yeah, but this is not just a matter of the machine. This is the matter of getting used to see the nerve. I mean, as Chandan just pointed out, if you can use the ultrasound only in intraop, you will not lose time. Actually, it will tell you exactly where the lesion is, the tumor, the continuity, the neuroma, the compression site, and so on. So it actually makes you faster. And once you get used to see a normal nerve, you will instantly see when a nerve is not that intact anymore, or if some of the fascicles are changed, like in the inflammatory conditions that we are seeing more and more. But it's not just a matter of having a fancy machine. The fancy machine is up here. This is what you need. You need to get used to it and to learn it. And but in most of the countries that I've visited, it's not a lot, but the ones that I saw, most of the anesthesiologists, just for the regional anesthesia, they had an ultrasound machine with at least 10 megahertz, even if it's 10 years old, it doesn't matter. So you will see perfectly what exactly you're looking for. So I can only encourage everyone to just do it.
Yes.
Thank you. Thank you, Christian.
Thank you.
I had one comment and question to Professor Imam Mahdi's talk. It was a wonderful talk. I think it just shows you that the peripheral nerve surgery is now is so much more varied. It's just not about small tumors or entrapments or brachial plexus injuries. Now we are at forefront of rehabilitation and recovery of function after something as devastating as spinal cord injury. I had one question on Professor on his talk. Do you have any experience with bladder reinnervation after spinal cord injury? Because that is something which is coming up.
Yes, I'm going to do and planning for this bladder regeneration in the future. I wrote the proposal and I'm waiting for. I did about this kind of nerve transfer cadaveric study have done, and I'm ready for clinical one.
Thank you. Thank you. I think time is up for our discussion.
Excuse me. Another comment, please. I have done also coronial neurotization when there is no sensation on cornea. We use the contralateral supraorbital nerve with graft and bring it the other eye which has not sensation. With my ophthalmology result was very excellent. I will explain in Dubai, I hope.
Thank you. We have to move. Discussion time for discussion is finished. Excellent presentation, excellent discussion. Now we are going to the interview of a legend, true legend. Keep on rolling and beyond regarding peripheral nerve surgery. Mariano Sokol will be conducted by Dr. Adilson